In this video, let's focus on the following topics, starting with a question from squamous odontogenic tumor. I guess there was a question on the same. Let's review some literature pertaining to that. So as you can see, squamous odontogenic tumor, also called as benign epithelial odontogenic tumor. In maxilla, the lesions are centered around the incisor cuspid area, whereas in mandible, the lesions have a predilection for bicuspid molar area. And most importantly, significant keratin formation also is not typical feature of squamous odontogenic tumor. So those are some of the keywords which I researched pertaining to this question. See if it's helpful in answering the same. Now moving on to the next question, tenderon percussion. So in which of the following situations is tenderon percussion positive? So if you review literature, pain on percussion is a classical diagnostic feature of symptomatic apical periodontitis. The symptoms are either the result of irritation originating from endodontic treatment caused by over-instrumentation, medicinal irritants or overfilling, in which case the tooth is obviously pulpless, or the result of noxious stimuli irritating the periodontal ligament, in which case the pulp is vital. Also, if you look into this table, in case of reversible pulpitis, symptomatic irreversible pulpitis, asymptomatic irreversible pulpitis, pain on percussion is negative. Right? Moving on to the next question, we have various distalization appliances. Here is the list for you. So, molar distalization, we have the following devices or instruments which can be used extraoral as well as intraoral, including implant supported. See if this information is helpful in answering a question. I think there is a question asking which of the following is not a distalization appliance. Right. Now moving on to the next question, indirect causal association between the endemic goiter and the altitude. So if you look into the literature, association between high altitude and endemic goiter. Endemic goiter is not due to high altitude but due to low iodine content in soil or water, which is the cause of association. Statistical association between high altitude and goiter is not necessarily causal. Here this falls under the example indirectly causal association, right? Also we have directly causal association and also spurious association, right? So this is some literature pertaining to this question. Now moving on to the next topic, what is diffusion hypoxia? Let's review some literature pertaining to the same. So the second gas effect and diffusion hypoxia are some of the topics which we discussed even in E-classes prior. During anesthesia administration, when nitrous oxide is discontinued after prolonged anesthesia, nitrous oxide having low blood solubility rapidly diffuses into the alveoli and dilutes the alveolar air. As a consequence, the partial pressure of oxygen in alveoli is reduced and the resulting hypoxia is called as diffusion hypoxia, right? So it's not of much consequence if cardiopulmonary reserve is normal, but may be dangerous if the cardiopulmonary reserve is low. And this can be prevented by continuing 100% oxygen inhalation for few minutes after discontinuing nitrous oxide instead of straight away switching over to air. Right? Now moving on to the next question, vaccination in asplenic individuals. And they also mentioned one of the characteristics, lab characteristics of the microorganism Quilling reaction positive. So it should be most probably Streptococcus pneumoniae based on the literature which you can see now. So asplenic or hyposplenic individuals are particularly vulnerable to invasive infections caused by encapsulated bacteria. Updated recommendations on available vaccines were consequently provided. Vaccination against Streptococcus pneumoniae, Neisseria meningitis, Haemophilus influenza type B and influenza virus are strongly recommended and should be administered at least 2 weeks before surgery in elective cases or at least 2 weeks after the surgical intervention in emergency cases, right? So just review this additional literature and see if it's helpful in answering a question. Now moving on to the next topic, cavernous sinus thrombosis. Which of the following cranial nerves is often affected first? So if you review literature, cavernous sinus thrombosis is a rare life-threatening disorder that can complicate facial infection, sinusitis, orbital cellulitis, pharyngitis, otitis, etc. So local compression and inflammation of cranial nerves can lead to several partial or complete cranial neuropathies, including the following: diplopia from partial or complete external ophthalmoplegia due to compression of 6th, 3rd and 4th nerves. Limited eye abduction from the abducens palsy is most common early finding, often progressing to inability to move the eye in any direction when 3, 4, 6 cranial nerves are involved. Right? I hope this answers your question. Now, moving on to the next topic, salivary imaging with gamma camera, hot, cold, normal. Let's review some literature pertaining to the same and see if it's helpful in answering a question. Preoperative diagnosis has been greatly aided by scanning with technetium-99m PET technetate. Tumors that appear as hot spots are almost always Wharton's tumor or oncocytomas. Most other neoplasms show either normal uptake or appear as cold nodule, as mentioned in one of the literature. And if you look into another article, it's clearly mentioned like what do you call as cold, warm or hot. So salivary imaging with gamma camera interface to a computer allows rapid sequential images and assessment of 3 distinct phases, that is blood flow, which is uptake, the functional, that is concentration and storage, and washout, that is drainage of the tracer. The activity is compared with the normal tissue surrounding the lesion during these phases, and one of the 3 patterns is noted, that is either cold, warm or hot. A scan is cold if the lesion does not concentrate PET technetate as much as the normal gland. A scan is warm if the uptake is similar between the lesion and normal tissue. A scan is hot if the lesion displays increased PET technetate uptake. Now, moving on to salivary gland neoplasms, especially parotid neoplasms. Classically, 2 parotid neoplasms yield a hot PET technetate scan. That is Wharton's tumor and oncocytoma, as we discussed prior. Some pleomorphic adenomas can appear with mildly increased uptake of PET technetate, but remaining benign tumors do not. Right? So, see if this information is helpful in answering your query, and if you need any additional information, do let me know. We'll update that accordingly in the description part of the video. Right? Moving on to the next question, gold-based alloys indications. So let's review some literature pertaining to the same. So type 4 gold alloys are those which are used in high stress areas such as bridges and partial denture frameworks, right? Also you can find the indications of type 1, type 2 as well as type 3. I think there was a case-based question asking you what if you're planning to replace a second premolar and first molar, which are the following gold alloys would you prefer, isn't it? Now moving on to the final topic, visual field defects. This is purely learned based on observing the image. So in this image you can see visual field deficits resulting from damage at different points along the primary visual pathway. The diagram on the left illustrates the basic organization of primary visual pathway and indicates the location of various lesions. The right panels illustrate the visual field deficits associated with each lesion. A represents loss of vision in right eye, B represents bitemporal hemianopsia, C represents left homonymous hemianopsia, D represents left superior quadrant anopsia, E represents left homonymous hemianopsia with macular sparing. So coming to question in specific, they might have asked you like what happens when there is any lesion at the level of optic chiasma or crossing. So damage to optic chiasma results in visual field deficits that involve non-corresponding parts of visual field of each eye. For example, damage to the middle portion of optic chiasma, that is B, as you can see in the image, which is often the result of pituitary tumors, can affect the fibers that are crossing from the nasal retina of each eye, leaving the uncrossed fibers from the temporal retinas intact. The resulting loss of vision is confined to temporal visual field of each eye and is known as bitemporal hemianopsia. It is also called as heteronomous hemianopsia to emphasize that the parts of visual field that are lost in each eye do not overlap, and individuals with this condition are able to see in both left and right visual fields provided both eyes are open. However, all the information from the most peripheral parts of visual fields, which are seen only by the nasal retinas, is lost. Right? So this is some information pertaining to visual field deficits. Also, I'll share the link of the article. You can go through additional information at your convenience. Right? So these are some of the topics which I wanted to highlight in this specific video. You need any additional information, do let me know in the comments below. We'll update that accordingly in the description part of the video. I hope it's clear. Wish you all the best. Love you all.